Welcome to today's NephCure U webinar on KDIGO Guidelines Explained. My name is Kristen Hood, NephCure's Director of Clinical Outreach, and I will be the moderator today for this educational webinar. I am so excited about today's webinar, but before I introduce our speaker, I'd just like to let everyone know that we will offer a Q&A session at the conclusion of this webinar. So if you will please drop your questions throughout the webinar down in the Q&A toolbar that you see down at the bottom of your screen within the Zoom toolbar. I will moderate those questions at the end of the session. This webinar is being recorded and will be posted to NephCure's website as a patient resource. And finally, I'd like to recognize some of NephCure sponsors who help programs like this become available to you. Travere Therapeutics, Mallinckrodt Therapeutics, Boehringer Ingelheim Pharmaceuticals, and Konica. Thank you so much for your support of NephCure educational initiatives. And now it's my pleasure to introduce to you Dr. Brad Roven. He is a professor of nephrology at the Ohio State University. Dr. Rovin received his Bachelor of Science in Chemical Engineering from Northwestern, his Doctor of Medicine from the University of Illinois in Chicago, and completed his residency in internal medicine at Barnes Hospital in St. Louis, followed by a fellowship in nephrology at WashU in St. Louis. He joined the Ohio State University medicine faculty in 1990, became the director of the Division of Nephrology in 2004, and served as the vice chairman of medicine for research from 2009 to 2019. In 2019, he became the medical director of the Ohio State University Clinical Research Management Institute. He has several leadership roles in the American Society of Nephrology, including running the glomerular disease pre-course and co-editing NephSAP, which is a continuing education program for the society. Most recently, he was appointed deputy editor of Kidney International, the flagship journal of the International Society of Nephrology, and he's also the co-chair for the Glomerular Disease Guideline Development for KDIGO, which is why we have invited him here today. Dr. Roven studies immunopathogenesis of glomerular and autoimmune diseases. He's heavily involved in clinical trial development and design for investigator-initiated and industry-sponsored trials. He is a founding member of NephroNet, a grassroots nephrology community clinical trial organization, and the Lupus Nephritis Clinical Trials Network. He is and has been the principal investigator on several trials for novel therapeutics for glomerular diseases. He is the expert, and that is why we are so happy to have him here today. With that, Dr. Roven, I'm going to turn this over to you.
Well, thanks, Kristen, for that very nice introduction. And I've been working with NephCure now a few years, and it's my pleasure to do this. So I'm going to talk a little bit about the KDIGO guidelines and then some other things about clinical trials. And these are all of my work that I do for the pharmaceutical industry, and I will try to not let anything get in the way of this this talk. So KDIGO is sort of an interesting name, and it really is an anagram. It stands for Kidney Disease Improving Global Outcomes. And the KDIGO mission is listed here, but basically this is a top-of-the-line organization that develops and implements clinical practice guidelines. And it's global, so that when we tailor the guidelines, we have to take into consideration that they'll be used in countries like the United States, but also in other countries that may not have as many resources as the United States. Okay, this is a little bit of the history. I don't want to spend a lot of time here. This started as an offshoot of the National Kidney Foundation, which is a U.S. Entity, and then it started to explore becoming its own organization in the early 2000s. It's incorporated in Belgium, as it turns out, as a nonprofit. In 2012, which happens to be the very first year I became involved with the KDIGO organization, and we wrote the very first guidelines on glomerular diseases, it became an independent entity no longer associated with the National Kidney Foundation or any other society. It's a society in and of itself. And over the years, it's led by volunteers, and over 1,000 clinicians and scientists have participated. It's important to understand that KDIGO is funded by a lot of sources, but there's no direct funding solicited from the pharma industry for guidelines or updates. And all of the work group members, including myself, submit financial disclosures so that the guidelines are as objective as possible. Okay, just a word about what a guideline is and how they're developed. Guidelines are meant to help practitioners in the field, and in this case, nephrology, and in the field of glomerular diseases, manage, not only treat with drugs, but manage in a global sense the entire patient with a specific disease, and in this case, glomerular diseases. So once we identify the need for a guideline, and that was identified the first time for glomerular diseases in 2012, a evidence review team, which is an independent team, goes through a systematic review of the literature. And this doesn't mean simply reading the papers. They do this in a very statistical way. They're called meta-analyses. They compile all the data, and they take a rigorous look at the data, and they actually rate the evidence that has come from the clinical and basic science data that go into managing a patient. Work groups are formed. The work groups are generally experts in nephrology, in this case, experts in glomerular diseases, and they're chosen from around the world. So we have a very broad and diverse perspective of how to manage disease. And we also often include patients in some of the guideline meetings to help. And then there are experts in writing guidelines who actually help us as well. We draft a first working document of the guidelines, and then that is sent out to the entire nephrology community. And it's really available to anyone who wants to look at it. It's online. We often get physicians from other specialties looking at the guideline, and they can make comments on it. We get folks from the pharmaceutical industry also making comments on the guideline as well. Then all this feedback comes back to us. The review is out for about a month or so, and believe me, we get plenty of feedback. We address the feedback and actually incorporate and change the draft per the public feedback, as long as this is all evidence-based. And then eventually we publish and disseminate these guidelines. So this seems very simple, but it's actually a multi-year process. So far, this production for the KDIGO Glomerular Diseases Guideline has been worked on for about 3 years. We've already done the public feedback, and we're getting ready now to prepare. It's being prepared actually now for publication. So this is perfect timing for this educational session. Now, we did a couple of interesting things in the 2020, this should be really 2021 now, guideline format. So we make recommendations and we make suggestions. Recommendations are using the best information we have, and that generally is based on randomized controlled clinical trials that some of you may have participated in. And these recommendations are really what we think patients and physicians would and should want to do in managing the patient with any sort of glomerular disease. Practice points. Now, let me preface this by saying, as we go through this, I'm going to point out some recommendations, but we have very few recommendations because we have so little top quality evidence in many of the glomerular diseases. We can't just leave sort of the nephrology community hanging out with a couple recommendations and nothing to fill in the blanks. And so we also make practice points to help the physician really take care of the patient. These are based on a number of sources of evidence that are slightly less rigorous than a randomized controlled trial, or considerably less rigorous, because in some cases we have nothing else but expert opinion on how to treat or manage certain types of glomerular diseases. The emphasis on this, and I think this is a theme that is well carried out through NephroCure, is that we have a lot of opportunity in this field to expand our guidelines by doing more clinical trials that are randomized, blinded, done in an appropriate way. And eventually, over the years, I'm going to hope that we will get more recommendations and fewer practice points as the guidelines evolve. Now, the other thing that you might think about is that, of course, this is the era of everything being online. When we did this in 2012, which was the first and only iteration of the glomerular diseases guideline, it stayed that way for all those years, and it wasn't updated. And that's not appropriate. And clearly through NephCure, many of you know that we are advancing the field of glomerular disease research and clinical trials tremendously lately. And so the guidelines will be also online as well as in print, and it's called Magic App. This is the application. It's sort of an interesting name, but anyway, it will be updated in real time so that we can capture the data as it's coming out and really keep the guidelines as current as possible. So this is a major innovation over the first GN guideline. Okay, this is how we rate evidence. It's called grade methodology. This has been put together over many years. It's a well-validated methodology for looking at data from the literature and grading those data. Grade is either level 1 or level 2. Level 1 is the highest level, and we are recommending this. Level 2, less high, and we suggest it. Maybe pretty good, but not quite to the level of a recommendation. And then the quality of the evidence is graded A, B, C, and D. A is the best, high quality evidence. That usually means the problem has been studied by several randomized clinical trials using the same type of intervention, and that has demonstrated really the efficacy of that intervention with few side effects, that sort of thing. Very low grade evidence is unfortunately what we often have, and you'll see that many of the recommendations are graded in the C and D range. We have very few 1A recommendations. We do have some 1B recommendations that I'll show you today, and they actually appear in the pediatric glomerular disease arena, so that's sort of promising. Okay, I want to start out with focal segmental glomerulosclerosis. I've picked some of the diseases that NephCure is particularly interested in, which are proteinuria kidney diseases. And the work group was Adrian Liu and Jay Rodnick-Christian as the experts who worked on this particular chapter. And we reclassified, as you, if you will, FSGS, focal segmental glomerulosclerosis, because it's confusing. It's not a single disease, but it's really a pattern of kidney injury on microscopy, and specifically the filtering units of the kidney, or the glomeruli. And we've divided this up into primary FSGS, and I put some stuff down that we talk about, and some of you I know are patients or family members, and this may not have a lot of meaning to you, but we look at under the microscope at how the kidney appears in FSGS, and based on that and also some of the clinical attributes, we define a primary FSGS, which we believe is mediated by an immunologic process and amenable to treatment. Okay, then we have genetic FSGS that can be familial or sporadic. This generally has its origins in some damage to the foot processes which cover the glomerular filtration unit. And these are very difficult to treat. And presently, we don't really have any good therapies for genetic FSGS. Because FSGS is sort of just a histologic finding, you can see it in context of many other diseases. Viruses, it can be induced by certain drugs. There's a whole list of diseases. This is called secondary FSGS. And really, to treat the kidney means to go back and find out what has caused this and treat the primary cause. And then we have another category which we added this year, FSGS of undetermined cause. So we can see the pattern on light microscopy using just plain old microscope. It doesn't meet any of these other criteria, and we can't find a reason for it. And we see a lot of patients like this. Okay, so how do we think about treating patients like that? So once we find a patient who has a kidney biopsy that's consistent with FSGS, we divide that patient up into having nephrotic syndrome. As many of you know, nephrotic syndrome is having urine protein loss of over 3.5 grams a day, a low protein in the blood, low albumin in the blood, and this is often accompanied by swelling or edema. And then we look for certain findings on the electron microscope pictures of the kidney. And if we define this as probable primary FSGS, that is an FSGS that is amenable to treatment, we treat with immunosuppression, which I'll show you in a minute. And then if there's no response, we look at genetic testing. In the absence of this, so the person can have high proteinuria, but they don't meet the other criteria of nephrotic syndrome, or more often they don't have a large amount of protein. They have protein in their urine that's abnormal, but not a huge amount. That's most likely not primary FSGS, and then we evaluate the patient for an underlying cause. We consider genetics when it's appropriate, but what the key is for everyone is that we don't start immunosuppression, because immunosuppression generally won't work and exposes the patient to adverse events. Now, we should monitor, of course, for the development of nephrotic syndrome, because you could catch a patient early in the evolution of a primary process, and then we would take the person back into this part of the algorithm. So this has not changed since the 2012 guidelines, and you can see that this is a recommendation, but the quality of evidence is pretty poor. There's not a lot of studies in FSGS. We recommend that high dose oral corticosteroids be used as the first line immunosuppressive treatment for primary FSGS. And then for adults who have corticosteroid resistant primary FSGS, we recommend that cyclosporin or tacrolimus, these are called calcineurin inhibitors, and we use them a lot in the transplant field, be given for 6 months rather than continuing corticosteroids or not treating at all. And you can see that this is also a recommendation. The quality of the evidence is maybe a little bit better. This is a little bit disappointing in a sense that we haven't really progressed beyond what we've been using for many, many years for FSGS. And those of you who are patients or family members of patients know that high dose prednisone is something that most people do not really like taking. So I'm happy to say there are trials in FSGS that are ongoing, and we're hoping to find other therapies that are going to be better and less toxic. Now, one of the problems with FSGS is that it's very difficult to treat, and we see a lot of patients who are resistant to corticosteroids and or resistant to the calcineurin inhibitors. So what do we do then? Well, there's really no evidence at this point for any specific alternative agent. A whole bunch of different drugs have been used. They're listed here. But what I really want to point out is this bottom bullet point. Patients should be referred to specialized centers. What we're really trying to say here is that at this point, we need patients to come and be enrolled in clinical trials so we can move this field forward. And that's absolutely critical for this disease. Minimal change disease is a disease mostly seen in children, but we actually do see it in adults, usually in older age. And we treat minimal change disease in adults very similar to the way we treat it in children. We use prednisone, again, corticosteroids. And if there's a contraindication to corticosteroids, we have a menu of medications that we can use. Most adults will respond with remission, like children. They can relapse frequently or become dependent on the steroids, and then we will use something a little bit more potent to see if we can put the patient into a more long-standing remission. Now, I included treatment of nephrotic syndrome in children because it's really quite different than adults. In kids, we generally don't do a kidney biopsy unless the child is older. So if you have a child come to you who's newly nephrotic, so that is a high degree of proteinuria, swelling, low protein levels in the serum, and they're young, and they have no family history of this sort of disease, and they don't have any appearance of a syndromic disease, then the treatment of choice is again corticosteroids, prednisone in the United States. And kids generally will respond with, if they have minimal change disease, will respond very quickly. And we call this a steroid responsive nephrotic syndrome. Again, we have not done a kidney biopsy here. And if they respond, then we have, what we have done is actually recommended to shorten the treatment to 8 to 12 weeks as opposed to 6 months, because there's no evidence that longer treatment is better for the patient or prevents the relapsing, but it is less toxic because you're giving less total dose of steroid. Now, unfortunately, a lot of these steroid responsive nephrotic syndromes are relapsing diseases in childhood. And if the patient is relapsing only occasionally, then they get treated periodically with steroids. If the patient becomes dependent on steroids, so in other words, you cannot taper out the steroid off and get rid of it, or the patient relapses as you're doing it, then we use some of our stronger immunosuppressive drugs like mycophenolate, rituximab, cyclophosphamide, or calcineurin inhibitors. Similarly, if the patient is a frequent relapser, so you can get the child off steroids, but then after a period of time they relapse, you treat, they remit, they relapse again. We really want to limit the amount of steroids in children. And so we can actually usually get a more sustained remission using medications like this. And again, cyclophosphamide comes up. If the patient was treated with corticosteroids and they have not achieved a response in the first 4 to 6 weeks, that's pretty unusual, suggests that the patient does not have minimal change disease and probably has focal segmental glomerulosclerosis. And so at this point, we often recommend children have genetic testing to see if they have an FSGS that's due to an abnormality of a protein in the foot processes of the podocytes, which cover the filtration area. We often will recommend that the child has a kidney biopsy. And then as second line therapy, we do add a calcineurin inhibitor to the regimen. Okay, one of the most important diseases, and something that I think we actually have now some hope for is IgA nephropathy. IgA nephropathy is the most common glomerular disease in the world. It's particularly prevalent in Asian countries. We have a considerable amount of IgA nephropathy in the United States. This is the work group, all experts in IgA nephropathy, who developed these guidelines. And IgA nephropathy is a very interesting disease. This is generally the algorithm for management. Proteinuria over 1 gram per day is really an important metric for patients with IgA nephropathy. What we generally do once we see a diagnosis of IgA nephropathy is we absolutely have the patient have meticulous blood pressure control. And we like to control blood pressure with, these are called RAS inhibitors, but this stands for the renin-angiotensin-aldosterone system. Some of you may have this entity, and we're using drugs that are called ACE inhibitors or ARBs. These are antihypertensive drugs, but they also have the ability to decrease proteinuria in the urine in patients with glomerular kidney diseases, and they also are kidney protective. And so we recommend that once the diagnosis is made, whether or not that patient with IgA nephropathy has hypertension, that they be started on an angiotensin converting enzyme inhibitor or an ARB. And this is a 1B recommendation. So there's pretty good evidence for this recommendation. And the goal is to treat them with the maximum dose that's tolerated. And we want that urine protein to drop below 500 milligrams or half a gram a day. Why is that important? Because we know from natural history studies of this disease that the lower the proteinuria, the better the long-term preservation of kidney function is. Patients with over a gram of proteinuria per day that can't be brought under that tend to actually progress over many years toward end-stage kidney disease. So, if we do all this and the proteinuria remains over 1 gram per 24 hours, this is where the clinical trial comes in again. Up until now, we've had no specific therapies for IgA nephropathy. And so we really recommend considering enrollment in a clinical trial. There's about 5 or 6 clinical trials now. Some of them are starting to read out with very promising results. And the IgA community has been really accepting of these clinical trials. We've been able to enroll trials using several different types of therapies very well, even during this pandemic. And so just stay tuned because you're going to see the results of this coming out soon. So if there isn't a clinical trial and the patient has fairly severe kidney dysfunction, then we really recommend supportive care. This person is unfortunately probably going to progress to end-stage kidney disease and need renal replacement therapy. On the other hand, if the GFR is okay, not necessarily normal, but certainly not very, very low, then we consider putting the patient on a corticosteroid. And we take several things into consideration when thinking about corticosteroids. And one of the issues is that corticosteroids still have sort of a difficult record in terms of interpreting the data as to their efficacy in IgA nephropathy. One of the things I thought was quite good in this chapter is because the clinical benefit of corticosteroids is not well established, we really want physicians to consider what other things are going on with that patient before they put them on high doses of corticosteroids. And these things, especially as you know, diabetes, giving a diabetic patient steroids can make the diabetes come out of control, obesity, patients with latent infections, patients who have stomach issues, patients who have psychiatric problems. These might be relative contraindications to giving steroids. You really have to balance what could happen with the benefit of steroids. And since the benefit of steroids is not particularly robust, these things can tip the scale into not using steroids. The other thing that I thought was very good about this chapter is that we all want to treat our patients, and we've tried innumerable agents for IgA nephropathy. And you know, everybody has a story of I gave a patient this and they got better, which is not evidence. So this is not the level of evidence we would put in a guideline. But what the guidelines did, the guideline work group did, is they looked at all of the therapies that have been given for IgA nephropathy, and you can see that they said not recommended, not recommended, not recommended, maybe in Chinese patients because that's the only patients we have data for. And the point is that what we want to try and do is urge people to not simply give immunosuppressive drugs for the sake of treating a patient, but think about what they're doing. If there's really no efficacy, then really encourage that patient to participate in a clinical trial. Okay, the last entity I want to talk about is primary membranous nephropathy. This is a very common disease in older adults, not so much in children or young people, but we do see it occasionally. This is the work group, an international panel of experts in membranous nephropathy. And we've made an incredible discovery that's helping the treatment of patients with membranous nephropathy. We finally found this is an autoimmune disease, it's an immune complex disease, and about 70 to 80% of the cases of membranous nephropathy, the patients have antibodies to this receptor. And this receptor is in the filtering unit of the kidney on the podocytes. Again, this is called the phospholipase A2 receptor. So in patients who have proteinuria, and who are antibodies to phospholipase A2 receptor positive, this is a blood test, and they are having normal kidney function and nothing else is going on, we are almost at the point where we can make a diagnosis without doing a kidney biopsy. And I'm assuming some of the folks in the audience have had kidney biopsies. It's not a terrible procedure, but certainly it's something you'd want to avoid if you could. Patients who are not antibody positive, but who have nephrotic proteinuria, they will get a biopsy. Now, because this is a new diagnostic test and it's really being developed, and we're just really starting now to understand the implications of the level of the antibody, and what that means, and how the disease usually gets better if we can control the antibody production with immunosuppression. We do want to biopsy patients where there's something else going on, or there's something that's not simple, straightforward membranous nephropathy. And so we've put a bunch of caveats in here. So if there's anybody in the audience who's had membranous nephropathy, you probably got a biopsy, and we're still doing quite a few biopsies for membranous nephropathy. But in the future, it's entirely possible that this disease will be a serologic diagnosis, in other words, a blood test, and we won't have to do biopsies. And that will be a real step forward in the management of patients with membranous nephropathy. Now, the treatment of membranous nephropathy has also progressed nicely over time. And so we have a recommendation here, and it's a pretty good level recommendation, 1B. For patients with membranous nephropathy and one risk factor for disease progression, we recommend using rituximab. Rituximab is a agent developed for cancer, but it kills B cells, and it's quite well tolerated, and it's showing efficacy in patients with membranous nephropathy. Or our old one, cyclophosphamide and steroids, which show incredibly good results, or a calcineurin therapy, and these are done for 6 months, and the choice is really depending on the estimate of risk. So you can see here, we've made this algorithm for physicians. Low risk patients, we tend to just wait and see because membranous nephropathy in about 30% of people can spontaneously resolve without any therapy. In patients with moderate risk, we can wait and see, or we can add something that is not highly toxic to start with. Rituximab is a good choice. A calcineurin inhibitor is also recommended or suggested. Patients at high risk and very high risk of actual progression, and progression, that means deterioration of kidney function heading toward the possibility of kidney replacement therapy, we really need to treat aggressively. And these are some of, this is a table of risk and the criteria for risk. And as you can see, these build up over time. Generally, the high risk patients are patients who have already impaired kidney function. They have a very high degree of proteinuria for a long period of time. Their phospholipase A2 receptor antibodies are quite high. Those patients tend not to spontaneously remit, and they tend to progress towards end stage kidney disease. And then some patients have very high risk where they have life threatening nephrotic syndrome. They're swollen, they have blood clots from the nephrotic syndrome, et cetera. Those patients should be treated, in my opinion, I use cyclophosphamide. That is so far the only drug for membranous nephropathy that's been shown in clinical trials to actually preserve kidney function for the long term. Okay, so this is sort of a glimpse as to what the guidelines will look like. The actual guidelines are over 500 pages long, and interspersed is a lot of advice on how to manage the patient and really improve the patient's lifestyle, minimize side effects from medications, and get that person back to being and doing what they want to do as much as possible. So then the NephCure folks asked to just talk a little bit about NephCure and clinical trial participation, and they gave me this frequently asked questions about clinical trials. I assume they've gotten this over years from the patients and families that work with NephCure, and I'm going to try and answer these questions. Of course, you can ask similar questions when we have the question and answer period. But anyway, when should I consider entering or inquiring about a CT as a clinical trial? So my recommendation is as soon as you're diagnosed with a glomerular disease, you want to ask about a clinical trial. One of the issues with nephrology, I'm going to be a little philosophical here, is we have not really gotten the therapies advancements like you see in the cancer world. In the cancer world, when I was a fellow, there were no therapies. There were very few. They made patients sick, and it was really, really difficult. And they didn't work very well. And then the cancer oncology folks got together and they formed all of these clinical trial consortia and rigorously started testing therapies um, and and offering every patient who came in with a certain type of cancer this therapy or that therapy depending on the type of cancer. And what they did was they progressed their field remarkably. As you know, now there's all sorts of immunologic therapies for cancer, et cetera, et cetera. We have not done that up until now in the kidney space, and I think this has been a huge effort to push this out through NephCure. We've written articles through the NephCure consortium. We make clinical trials out there for the public to see. And what we do in our particular clinic at my institution for glomerular diseases is that we have one or more clinical trials for every glomerular disease that we know about. So in other words, if a patient comes to me with IgA nephropathy, I, at the present time, have about 4 clinical trials that are up and running in IgA nephropathy. And we sit and talk about the clinical trial and we decide which one might be right for that patient. So if a person is working all the time. Maybe an infusion drug where they have to take off work is not appropriate for them, and so we would go with an oral agent. Other people have other situations, and so we try to find the right drug or the right trial for the patient and enroll every patient in a trial. And that way, we're trying to emulate what the cancer clinics have done so successfully to really advance our new therapeutics. So I say, as soon as you're diagnosed with a glomerular disease, ask your nephrologist about clinical trials. And then, what if my physician does not offer or talk to me about a clinical trial and nothing else is working? So, this is where I really will tell you that you need to be a self advocate. Um, you really have to say, wait a minute, I'm learning through resources like NephCure or lectures like this or the internet that there's clinical trials ongoing for what I have or what my family member has. Why aren't we talking about these? And really sort of push a little bit. This segues into the next question, which is, what if my physician is not supportive of a clinical trial? Um, this is a family audience, I'm assuming, so I'm not going to say anything untoward. I'm simply going to be politically correct and say you might want to seek out a second opinion. And for both of these frequently asked questions, I'm going to show you the NephCure Gateway website in a second. That could be a very good starting point for you to start to seek out information. Is it ever too late to enter a clinical trial? And unfortunately, my answer is sometimes. All trials have inclusion and exclusion criteria. And we, as a tertiary referral center at the university, unfortunately often see patients who have been through maybe steroids or, whatever their primary physician has done. They haven't responded, but unfortunately they've progressed. And if they have enough progression, then they might not qualify for a clinical trial because it decreases the likelihood that they would achieve benefit from this drug or any drug. And so that's why we want to find patients early. And that's why I say, as soon as you're diagnosed with a glomerular disease, start thinking about a clinical trial. And this last question is really interesting. If I'm in partial remission, should I consider a clinical trial? We have plenty of glomerular diseases where we get patients into partial remission but not complete remission. And in many of those diseases, the partial remission is beneficial, but it is not necessarily going to prevent ultimately a deterioration of kidney function, development of chronic kidney disease, and even maybe going on to end stage kidney disease. And so that's very design dependent. There are clinical trials designed specifically to recruit patients who have not had a complete response. And the goal of those trials is to achieve a complete response. So that you have to sort of work with your provider to see what trials are out there. Now, one other tool you can use is the Kidney Health Gateway that was put together by NephCure. This is sort of the first page of this that you'll see on the web. It's a patient-centric clinical trial matching tool. And the other thing that's really cool about this website is that by your zip code, you can find people who have been involved with NephCure or at least vetted to some extent by NephCure that are specialists in your particular glomerular disease. And that could allow you to either call them or have your physician call them and talk to them about the possibility of a clinical trial. The other thing that's really nice on this website is that it really has a patient-friendly, it has a listing of clinical trials. And this is just one screenshot of part of the table. It has tables for patients and it has tables for physicians. So physicians can use this resource as well to look for clinical trials. But this gives you an idea of the vast array of clinical trials that are out there that has been curated by the NephCure people. And this page is all dealing with focal segmental glomerulosclerosis, but they have IgA trials and membranous trials and minimal change trials. So this is a nice way to even let you start to see what some of these things are. I don't know if you would go into your own nephrologist and say, I want to be on the duplex trial, because that sounds good to me. I think that would be a discussion between you and your physician. But nonetheless, it gives you sort of an idea of what's out there, which I think makes you a much better informed patient, and of course, really allows you to advocate for yourself. So I think that's the last slide I have. And let me get rid of this. And I'm happy to answer questions. I know I went through that pretty quickly. The whole guideline is huge, as you know. But any questions you have, I'm happy to entertain.
Thank you so much. Do you mind, you can stop sharing your screen.
Oh, do you see my whole?
I see. Yeah, I see your desktop.
Okay, so let's see. Did that stop it?
Uh,
Oh, I see. There's a button. How about
yeah.
that?
There
Okay.
you go. There you go. Great. We do have some great questions coming in. So I'm
Okay,
just
good.
gonna kind of just go down the list, and we'll get to as many as we can.
Okay.
Angela has a question, and she says, how can you have proteinuria without nephrotic syndrome?
So nephrotic syndrome is a definition, and it depends on actually the degree of proteinuria. So we have plenty of patients. So you know, in a normal situation, we all have a little protein in our urine, and we usually have about 100 to 200 milligrams of protein. So that's like 0.2 gram. Okay, above that is called proteinuria. Now, we can have patients who have a gram of protein, 2 grams of protein. When a patient has over 3.5 grams of protein in 24 hours, that's called nephrotic range proteinuria. Why do we call it that? Because at that level of proteinuria, you're losing so much protein in your urine that you start to get systemic effects. Okay. One of the most noticeable effects is you develop swelling of your ankles. That's usually the first thing in many people that draws attention to the possibility of a kidney disease. Okay. But you also decrease your albumin in your blood. We would find that on a blood test. Cholesterol goes up because the kidneys or the liver starts making lipoproteins, and a lot of other things ensue, such as a hypercoagulable state, which means you're more subject to having blood clots and things like that. So the nephrotic syndrome is dependent on the degree of proteinuria being large, as well as the development of these other systemic effects from the loss of protein in the urine.
Great, thank you. Next question is about cyclophosphamide. Hannah is asking, what could the long-term side effects of cyclophosphamide be?
Yeah.
And she says, taken to induce a long remission for steroid-dependent minimal change disease in this case.
Yeah. So the cyclophosphamide, of course, is a drug we've borrowed from the oncology space. It's a chemotherapeutic drug. We don't use it in the doses they use for chemotherapy because we don't want to kill everything. We just want to inhibit the immune system. So the short-term side effect, of course, is like any other immunosuppressive drug, you're subject to infection. Okay, we all know that. The long-term side effects really are dependent on the cumulative dose over your lifetime. So if you have lots of cyclophosphamide, over 36 grams over your lifetime, which we completely avoid, by the way, you are subject to cancers down the road, actually, blood cancers like leukemias and lymphomas. Okay, so we're very careful, and we have that in the guideline. Don't exceed X grams. That's usually in adults. For younger people, the unfortunate side effect is sterility. You can actually damage the ovaries or the testes, and you can become sterile. Now, for children, who are under the puberty age, usually this is pretty safe, and that's not really an issue. As you get into puberty and above, this really does become an issue. And so what we do with cyclophosphamide is we try to give the lowest dose possible, and we try to do ovarian and testicular protection using hormonal therapies. So, and we're pretty good at that. Now, if somebody, the incidence of, for example, premature ovarian failure with cyclophosphamide increases as you get older. And so a young person maybe can take X number of grams of cyclophosphamide without being at risk, but an older person, and I'm not saying old, but premenopausal person can take less. And so we're very cognizant of that. And the truth is that many of the clinical trials these days are designed so we may never have to use cyclophosphamide again. Okay, not that it's a bad drug. I use it all the time. It's a great drug. But if you can get the same effect with something with less toxicity, that's what we're shooting for.
That's a great point to make. Another question, for FSGS, where kidney function is still normal, is blood pressure medication the only recommended treatment?
Yeah, so when we have FSGS, and I'm assuming your doctor has diagnosed primary FSGS, we're going to try to treat you with blood pressure medications, which are those renin-angiotensin aldosterone inhibitors, and decrease the proteinuria as much as we possibly can. And we know that if we can get the proteinuria below a certain level, the patient really does very well over time. If after being on a ACE inhibitor or an ARB, the person still has significant proteinuria, and usually that's in the 3 grams or more range, then we're going to move that, or we're going to suggest to that patient that we consider a therapy with an immunosuppressive drug.
So Angela followed up with a question, are hypertension drugs suggested for other kidney diseases? I think she was referring to when you were talking about IgAN. So are hypertension drugs a pretty common medication to use in glomerular diseases?
Yes, so there's 2 ways to think about this. Hypertension in a patient with proteinuric kidney disease, so most glomerular diseases, can really accelerate the downward progression and damage to the kidney. Okay. Hypertension also makes you have more protein in your urine. You can think of it as pressure. Pressure is high, you're pushing more protein out. And often what goes along with hypertension is a high salt intake. Salt, your body's in balance with sodium. So when you take in a lot of salt, you pee out a lot of salt to keep a sodium balance. And where salt goes, protein follows. Okay, so this is all tied in together. So the very first thing we have to think about is if a person has hypertension, it must be controlled meticulously. The second thing we think about is, what are the best drugs to control that hypertension? Well, I can give you Procardia, but that's a vasodilator and that might make protein in the urine worse. But I can give you an ACE inhibitor, which is an antihypertensive, and it decreases protein and it reduces pressure inside the kidney, so it's protective of the kidney parenchyma. So now I'm going to choose that. Okay. Now, your question is more broad. Is that the idea for all of our glomerular diseases? And yes, in the very first chapter of that guideline, we have general care of the patient with glomerular diseases. And like the number 1 recommendation is ACEs and ARBs in our patients to reduce the proteinuria and protect the kidney.
Great, thank you. Sean has a question. Can you clarify whether FSGS, where kidney function is normal, is considered FSGS of unknown cause, or could it still be caused by genetics or a secondary cause?
Yeah, the kidney function, a lot of times the kidney function is normal in FSGS. The way we actually look and try to determine sort of one of those four groups of FSGS is by the degree of proteinuria, okay, and also by the symptoms that the patient has. So, in fact, you're right. If I had a patient, and I have lots of patients like this, who have pretty good kidney function, they have 2 grams of proteinuria, I do the biopsy, they have FSGS on the biopsy, so they don't have nephrotic syndrome, okay? So right away, you're thinking, well, they're not really a primary FSGS. I do a workup with, looking for all those other causes, drugs they might be taking. I mean, not drugs, I mean, prescription drugs, obesity, things of that nature. And I can't find anything. Then I'm going to call them FSGS of unknown. But I watch that patient carefully, because if they progress to start having proteinuria that's really nephrotic range, and they get edema, and their serum albumin drops, then I'm going to start thinking maybe they're a primary I just caught early, and I'm going to consider therapy for them. Now, in adults, the genetic causes for FSGS are much more common in kids than adults. We have traditionally suggested not doing genetic testing very often in adults unless there's a specific reason. That is a changing field, because as we learn more, when we start doing whole genome sequencing, we're seeing that adults have a lot of abnormalities of the glomerular basement membrane and things of that nature. And those things can cause an FSGS-like picture as well. So I think there's a little finesse here as to sort of what you call the disease and how you will treat it. But the reason we did this, and I'm just going to be 100% honest, is people come, they want to be treated with something, and most nephrologists sort of did a knee-jerk FSGS steroids. We were treating a lot of people with high doses of steroids that were never, ever going to respond. And they got a lot of side effects. And so we want to make it clear that you shouldn't rush into steroids without thinking about what kind of FSGS this is. Now, there's some exciting news coming down the pike. You might have seen some announcements from one of the sponsors of this particular symposium that they have a non-steroid FSGS drug that just met its first hurdle for the FDA. I'll just call it like that. And they are very excited about this. And that drug I could use in all types of FSGS because it's really kidney protective. So you see how the field is changing even as we're sitting here.
And with the importance of clinical trials, for sure.
Yeah.
Yeah, absolutely.
Probably emphasize that a lot. Maybe people are tired of that.
No, I mean, you know what? It's so important. It really is. And we appreciate you mentioning it. So another comment, thanks for the great overview. Can you elaborate more on why you think there has been new guidance for IgAN and not FSGS? Do you think IgAN is better understood, or is there simply more evidence-based data that informs the new guidance, such as considering trials earlier in the disease process?
Yeah, so I think one of the issues with the FSGS not moving forward as rapidly as IgAN has been sort of this muddled picture of what FSGS is. And we spent innumerable hours discussing this in our various meetings with the Guideline group. I think the most important thing I put in that, I didn't write that chapter, we put in that chapter was FSGS is not a disease. FSGS is a pattern seen on the microscope, and it encompasses lots of diseases like I showed you. That really makes studying FSGS, primary FSGS, very difficult. And so there have been trials in FSGS, but they're all mushed together with people of all different kinds of FSGS, and they weren't ever really spectacular trials because probably some people had genetic FSGS that not going to get better with immunosuppression. Some people had FSGS because of obesity, not going to get better with immunosuppression. On the other hand, IgA nephropathy is an autoimmune disease. We have a much better idea of its pathogenesis. It doesn't come in the variety of flavors that FSGS comes in. We see IgA nephropathy isolated to the kidney. We can see it in a systemic fashion with IgA vasculitis, which is much more common in kids than adults. And so we really focused in on the pathogenesis of this. We have good animal models of IgA nephropathy. And this is how these trials came to bear. And I'll say one other thing. I work with all the pharma. You saw what my disclosures were, but pharma is reluctant to, get into a morass. And FSGS has really been considered a morass for a long time. Now that we've made some strides in this and we really understand a little bit more about the varieties of FSGS, you're going to see some really cool trials. And even on that list of trials that I showed you, we're participating in some really interesting trials. And there's even some trials coming out now. Well, they're in the design phase, but I'll just say that the idea is to substitute for the proteins that might be aberrant because of a genetic deficiency. And that's really exciting because that might open up a whole new area for FSGS treatment.
Absolutely. I'm going to just ask one more question. I know we are out of time. You're good? Okay.
I'm good.
Okay. So another question, what is being done to maybe unify nephrology community around these standards, and how are they distributed? And do you think that most nephrologists follow the guidelines?
Yeah, so that's a really, really good question. So we're doing lots of things. The KDIGO guidelines are highly anticipated, and I will tell you that when they're published, if you look at the number of hits or looks or likes or tweets or whatever, they're in the tens of thousands. So they're really well accepted in the community, and they're highly anticipated. And so I do think people more and more use the guidelines. I think that you'll see some variations in practice, and experience has a lot to do with it. And there are little things to finesse as you're going along, which I didn't go over today with the practice points. Like, if X happens, then consider Y and Z. Okay. So I didn't get into those details, but so that's really an effort. And the KDIGO people do a lot. They create conferences for us to give talks at every major nephrology meeting throughout the world, to promote the guidelines, and not in a profitable way, just to get it out there for the nephrology community. We have countless editorials in Kidney International and other journals about the guidelines. And then, we are also trying to develop uniform ways of thinking about glomerular diseases. And this really, all credit to NephCure. This is how I got involved with this, is they put together this community of clinical trialists from all over the world. And we had several meetings in DC, and we started to put together ways to make the approach to glomerular disease trials and patients uniform. And our first editorial is really, I think it's coming out in the next issue of Kidney International. I had the privilege of participating in that one, which is really a call to arms for the whole nephrology community. And by putting it in an international journal, Kidney International really has got a global audience. Well, all the major kidney journals do, but we are the ISN official journal, International Society of Nephrology official journal. We really think this is going to get out to people. So we're not quite there yet where everybody's doing the same thing. There's still a little bit of art to medicine, but I think the goal of KDIGO and the goal of NephCure is to put science in medicine, and do everything that we can evidence-based. And I think we've made a good stride in that direction. I don't think we're 100% there yet, so obviously more work to be done. But I think, again, many of you on the call are probably patients and patient families. You need to push this a little bit too when you see your doctor and say, hey, maybe I should look at this clinical trial. And nobody ever comes to me and says that. And I would like that. Really would. But of course, I'm the fourth person, the fourth nephrologist they see. But anyway, that's sort of my thoughts on that. But I think we've, believe me, I used to play with rats and mice. That's how I did my training. I was a very basic scientist, and now I'm much more translational. But I've been doing clinical trials now for about 12 to 13 years, and we have come so far over that period of time in engaging the nephrology community. It's been sort of one of the best parts of my career, I've got to say, and something I didn't know would happen, but it did. So.
No, it's great. And I'm going to just one more question. We have so many questions, and I will tell you, those of you that are hanging in with us, if I didn't get to your question, which is most of you, I will either get you the answers from Dr. Roven, and I'll email you, or I can get you the references and the answers through different NephCure resources that we do have. So flipping the side, you just got done giving this great answer around the nephrology community and how are you, as far as the physician community, really embracing it? Did KDIGO, in this new update, in the guidelines, did they consider patient-reported outcome measures, and how did they incorporate the patient into these new guidelines as far as really talking with the patient?
Yeah, so we have an initiative right now. It's not part of KDIGO, but it segues right into with KDIGO. It's called the SONG Initiative. And this is entirely patient-driven and patient-reported outcome. And so what we've tried to emphasize in the guidelines is that this is part of what we want to achieve. Okay, that's one thing. And the second thing is the song is Song GN. It's called Song GN, is coming out now with its results of all of the patient interviews and meetings that we've had. And most of the KDIGO folks have been involved in the Song GN as well. And so that segues nicely. So there's the flavor of patient-reported outcomes in the whole document you can read, and there's, for each recommendation, there's an entire section on how to think about this in terms of what the patient wants or would want. Okay, now we were supposed to have patients in on all our meetings. That didn't actually. A lot of the KDIGO does guidelines for all the aspects of kidney disease, and I know that in some of these work groups, they did have patients come in. Our work group was huge. So this wasn't like the diabetes guideline with 5 people. This was 30 people, and we're shipping them all over the world. And so somehow we actually, I had identified some patients that might want to do this, as did some of the other folks. And then there were patients who didn't speak English, and it became logistically difficult. And I'm not making excuses, but at the same time, the Song Jian work started. And so what we've done, what we're trying to do, is have the guidelines published in the same issue of Kidney International as the Song Guidelines come out with patient-reported outcomes, so that we put the two together for the community. So this is sort of what we've thought about for doing that for Kidney International.
That's great. Thank you so much. We have gone over our time. I really appreciate your time, Dr. Roven. We do have several questions, but like I said, if there are some that I think that I might just pass them on to you, and you can email me back, and I'll get it to the patient. This has been enlightening, and we really appreciate it. I think this gives a whole new sense of education and awareness to our patient community around how people like you and the experts in the field really look at treatment options. And I must say that incorporating clinical trials into these guidelines, I think, is a critical point for all of us, because honestly, we are in this pivotal moment of innovation and discovery. And in order to make advances within the drug discovery, we've got to have patients included in these clinical trials. So I do really appreciate that perspective, because we know that that's going to be the future for our patient community.
Mm-hmm. Yep.
But
very good. Thank you.
Thanks so much, everyone. Thanks for being here. Remember, you can go to nephcure.org if you want to find more information about NephCure Kidney International, and the Kidney Health Gateway. You can find that at kidneyhealthgateway.com. That is our clinical trial finder, and you can also find a glomerular disease specialist in your area by zip code. So thanks so much, everyone. Have a wonderful Monday. Great week.
All right. Bye-bye.